Welcome to How I Doctor, where we're bringing joy back to medicine. It's Graham Walker. Hope you're having a great start to the summer. This week, we're doing something a little different, a first for How I Doctor. No new episode from me. Instead, I want to hand you off to a show I think you're going to love. A few weeks ago, I sat down with Dr. Wendy Dean, the co-founder of Moral Injury in Healthcare, who basically handed our entire profession the language for something we've all been carrying alone. It was one of my favorite conversations I've had on this show, and I walked away thinking, we need more of this. Wendy co-hosts her own podcast called 43cc with orthopedic surgeon Dr. Matt Ramsey. Informal, informative, and irreverent is how they describe it, and I think we need more conversations like that. So this week in your feed, you'll find one of their episodes. Give it a listen, and if it hits the way I think it will, go find them on Apple or Spotify, search 43cc, and subscribe. Trust me on this one, you'll thank me later. I'll be back next week.
So, Wendy.
Matt.
Had an interesting day today. Another clinic day. Always some revelations in clinic. And it wasn't like this was an extraordinary day. This is kind of what my days are becoming now. But this one just got me because it's a father of a family of 2 young kids and a wife who is struggling financially with healthcare right now. And, you know, since I'm the guy delivering that care, you know, the cannons are pointed in my direction. And we got on the subject, and I've talked about this with my own experiences, is, you know, we are moving into a world where healthcare, moving sounds like we've moved into a world where healthcare is essentially unaffordable.
Yeah.
People are making and, you know, of course now we have a war going on and gas prices going through the roof and food going crazy, all that stuff. But, you know, this guy was telling me that he has a deductible, a $6,500 deductible for his health plan.
Oh my gosh.
I order an MRI of his shoulder because he needed it for me to help diagnose him. And that MRI cost him out of pocket $3,100. Which is just fucking ridiculous. Like, out of pocket. And we all know that if he had maybe thought a little differently about it, he might have negotiated a cash price, but that wouldn't count towards his deductible, so it doesn't get him any closer to realizing the benefit of his insurance. And, you know, my deductible is ridiculously high. In my health plan, it is not unusual. And on top of it, there are sometimes predatory practices in billing. Like, you know, we've all seen the TikTok video of the person who's saying, okay, I have an MRI prescription for my knee. What will it cost?
Yeah.
What's the cash price? And they go, $500. And they're like, do you have insurance? Oh, yeah, I have this insurance plan. Oh, the price is now $1,800. Well,
Right.
I'm insured. Why is the insured price more? What do I have insurance for if the cost of the service? And it gets to so many aspects of what's wrong with healthcare right now. But, you know, my concern is that we are on a train that is unsustainable. We're watching the train crash, and I'm just waiting for somebody with a little bit of sense to say, let's stop this madness. Let's figure out a plan. And
Jane, let's stop this crazy thing.
exactly.
Right? Yeah.
I mean,
but,
I just don't understand it.
yeah. And what I'm seeing are all of these clinicians, physicians in particular, who are in your position day after day, are facing these patients who are facing ridiculous bills for their services. And the physicians are getting tired of this. It is wearing to go through that day after day after day. But when you look at these systems, they are so huge.
Yep.
That how do we even begin to make a dent in making change with those systems? It's not like you in your exam room can break up Optum, can break up United Healthcare. It's not like the individual clinician can make a big dent in big medicine. And so in order to escape that pressure and how bad that feels, they're looking at other options. And some are going out and they're doing DPC. Good for them. It's good for them. It's good for their patients. They negotiate these low rates on imaging. They negotiate low rates on labs, on lots of the pharmaceuticals. Some are going into concierge medicine, which is a little more problematic.
In what way do you find that problematic? Because I have a concierge doctor, so I want to know what I'm doing wrong.
Well, I mean, the way I look at that is you're basically just buying a spot on somebody's panel. It's not any different than traditional medicine. So I'm guessing that when you go to your concierge doc, they bill your insurance, they bill you for your labs, they bill you for your imaging. And so you're still using all of your insurance.
Within the system that
Within
already
the system.
exists. So
Exactly.
it's not transformational. It's
No.
just survival.
Right.
Financial survival.
And it's transactional because, that $5,000 goes directly to the physician or more and more and more to the academic practice that then supports the physician's salary. But it doesn't translate into necessarily better value for the patient. They get more time for sure. Right. But it's still, your patient would still be paying $3,100 for their MRI and would still have a $6,500 deductible.
Correct.
So, some of them are doing concierge. Some of them are doing versions of pay to play where it's a traditional medical model. I'm a busy surgeon. You want to move to the front of the line?
Yeah.
You pay me a little.
Yeah.
Or you pay me a lot. You pay me a few thousand and you get moved up to next week. And then there are others who are doing things that are, even more outside the bounds, I think, where they're starting to do unproven therapies.
Yeah. Cash-based
Where patients-
therapies.
Yeah, where patients are desperate. They want relief. Traditional medicine doesn't have good relief for everything. And so they're exploiting patients' hope and patients' wishes that the miracle they're talking about is actually going to work, even though nobody's proven that it will. And insurance isn't paying for it for a reason.
I always say to patients when we have these discussions about stem cell therapies not being covered by insurance, I'm like, don't you think if the insurance company thought a stem cell injection could keep you out of the OR, that they wouldn't pay for it? Like, they're dying to put me out of business.
Right.
Like, I'm a big cost center. Surgeons are. Surgery's a big nut for them to take. If they could put me out of business by sucking some fat out of your abdomen and, concentrating 86-year-old stem cells and squirting it into your shoulder would eliminate the need for surgery, they'd be all over that.
Right.
So
They'd be saying, take all my money. Great. Let's do that. So, I understand why physicians are desperate to get out of the system. But I worry about what we're setting up for patients, for good care.
Well, and I see it as there are these two forces at play, and one is that physicians just want to survive. They want, and it's not all
100%.
driven. It's not all driven by making money. What they're saying is, to me, the way I view like a concierge practice or even a DPC practice, is they are essentially saying, I cannot practice medicine in this model the way it's constructed.
Yeah.
If I practice medicine the way I think medicine should be practiced, I can't feed my family. So these are my options. They're limited, they're imperfect, but this is how I continue to do the work that I'm called to do or I want to do. And the impediment is the system. Like, there is not a single individual doctor or small group of doctors who are going to, out of protest, leave their current model and go into a DPC or a concierge model, and somebody in Washington goes, "Oh, we got to change this system. These poor guys can't make it." There's just, we are so unleveraged in this process that something has to happen. Like, we're disadvantaged legally in the system. I mean, we've talked about this in the past, but one of the last amendments, or maybe the last amendment to the Affordable Care Act, was Section 6001, which prohibited physician ownership or expansion of already owned hospitals. So there is currently a moratorium on building and expanding, and many hospitals that were under development when the ACA was passed had to shutter their construction. It was over.
And it's not only that; it's that when you don't have hospitals being paid the same as independent practices, right? Like the system is rigged. It's set up to advantage hospitals. And so I think Section 6001 is the final slap in the face.
The wet glove, the glove across your chops. Yeah, I mean, for sure. And, you were just talking about site neutrality. Is like, why does an insurance company or Medicare pay a hospital-based surgery center more than they pay a physician-owned independent surgery center? That's one of the big lobbying efforts now in Washington, is to say, let's make it site neutral. And I would argue it can go either way. I mean, I'd be more than happy to take the reimbursement that an HOPD facility gets, but I'd also feel pretty good about them coming down to my price.
100%.
Let's see if you can make, I'm not necessarily viewing this as I want more for me. I'm just saying I want there to be a level playing field.
Right. Level the freaking playing field.
Well, and to me, that's the biggest thing. So, I do not think I'm a skeptic on about, in a meaningful way, completely revamping the healthcare system. I think there are too many powerful players that have too much influence locally, regionally, nationally, internationally, who have more inroads in our current system, not only the healthcare system, but our political system. What I would love to see is just take the fucking gloves off. Let us compete with these people. Don't pass laws that disadvantage my ability to go out and say, okay, we're going to do this differently. We're going to transparently price our services. That then you can go to employers and say, look, you guys don't want to see these bills coming back to you for $150,000 when I can provide that service transparently, no additional cost, and if there's complication, the cost comes to me. That's what Keith Smith is doing at the Surgery Center of Oklahoma, and many others who have followed that model are doing. If we truly, I always laugh at the term that we're a capitalistic society, because I think that's complete bullshit. I mean, we love capitalism, and when it's
working,
like
the idea of capitalism.
Yeah, but you don't really, like, people who have kind of achieved a certain kind of level in our system do everything in their power to disadvantage everybody who's trying to get to the same place they are. Yeah. So they pass laws, they do all kinds of things they are monopolistic. So when we've talked about this in the past too, about as you see consolidation in a healthcare system or healthcare delivery in a community, your options as an independent physician start to become very limited very quickly. Where are you going to go to work? Where are you going to send your patients? If you're not on staff and it's a closed staff, you're screwed.
Right. It's the gated healthcare communities that we're creating, where the folks on the outside, it's not, I mean, it is. It's that we're gating the community so that the people on the outside can't get in. And in order for you to get in, you need to have a PCP. You need to drop your outside PCP, your DPC PCP, your concierge PCP, and move everything over to the mothership.
Yeah, that's exactly right.
And wow, like, talk about, if for no other reason than for choice, because not every healthcare system can do everything well. And so if we don't have choice, like, what are we doing?
Well, when you don't have choice, what incentive is there for people to continue to deliver exceptional care?
Right.
If you think about it, like if you own a market,
Yep.
why do you have to be top gun in cardiac surgery or orthopedics or medicine or endocrinology? You don't have to. They got to come to you. They have no choice.
It's Cory Doctorow's enshittification, right? We're going to make it really, really good to start with. And then once we corner the market, we can just dial it back. And we can dial it back to the point where we're providing good enough care that makes us a boatload.
Right. That's exactly right. So, I just think, there are efforts in Washington, House Bill 2191 and Senate Bill 1390, which are the physician-led and rural access to care bills, which are basically saying, look, the way I interpret them, there was a time when physicians led healthcare, when CEOs of hospitals were clinicians and nurses and people who were right there on the front lines. And you can make all the arguments you want. You can have your business people in the background. But we have gotten so far away from point of touch care between administration and the patients and the clinicians that why don't we just give it a go? What do we have to lose here?
Let's just try a pilot study. Let's just try a pilot. And also, we're at the point where we don't have capacity in most places. We don't have capacity that we need.
And we don't have the resource. We don't have the people to deliver the care. Why do you think? We've always talked about, not you and I, but the people that are bright young minds have options, right? They can go to business school, they can go to law school, they can go to medical school. The ones with a little bit of conscience tend to go to medical school, and the sharks go to law school and business school. But it's a pool of people that kind of, they have the intelligence to go any of that. Why in God's green earth? It's no shocker to me when somebody says, I got to peek under the hood of healthcare and I want nothing to do with it. Or if you're, God forbid, a medical student who's getting into their third and fourth years and they're starting to get a taste of what medicine is like, I'm going to finish my degree, but I'm going to go to work for Wall Street or an insurance company or somebody else because this whole practice of medicine sucks. So, the one way I see as an absolute home run is if you allow physicians the ability to be entrepreneurial and not have our hands tied behind our back. I don't want to go into a prize fight with Mike Tyson with my left arm tied behind my back.
Right.
I don't even want to go into the ring with him with no hands tied behind my back. But nonetheless,
without a hat on.
Right. Like a helmet, not a hat. I don't need a fedora. I need like a helmet and body armor. But just give, you will, if there are still people in this country that are passionate about what healthcare, the ideal of healthcare is, the reality sucks at times, but the ideal is still there. If you give them an opportunity to realize the right? To basically say, you will have the ability, all the things we've talked about, what society offers us as physicians in exchange for the extraordinary knowledge that we bring to the table. Self-governance, you can, you're afforded a reasonable living. You will have the ability to practice the way you see fit and deliver this care. If that promise is somewhere out in the market in reality at scale, I think you'll start to see people come back to medicine in bigger numbers.
Well, or to just frickin' stay. I mean, what really worries me is when I see these numbers about how many practicing physicians there are. It's 1 million practicing physicians, and I look at it and I say, okay, yeah, but how many are full-time equivalents? Right? And so physicians are melting away to the point where they can tolerate the systems that they're in. But a lot of times that looks like a 0.3 FTE, a 0.4 FTE. Some people are only a 0.25 FTE.
Mm.
And if we could just make healthcare easier to manage, give people more agency, give people more autonomy to care for patients the way they promised to do, so that the delta between work as imagined and work as done is smaller, I think we would have a much larger healthcare workforce. And my goodness, we need to get hurried up on that. Right.
Like now.
Yeah,
we are. And
right
now
now
might not be good enough, but now has to be now.
Right. And we can't possibly train enough physicians fast enough before 2030 when we're going to have that giant gap. But if we could stop the exodus, if we could plug the holes of people leaking out or melting out or walking out, we would have a much better chance of meeting the healthcare needs of our country in the next 5 to 10 years.
Yeah.
If we don't do that, we don't have a prayer. And I think when we're looking at physician-owned hospitals, physician-owned ambulatory surgery centers, they take care of the same patients with the same conditions, with the same physicians. They get better outcomes. They do it more cheaply. Like, I don't understand why we haven't, I don't know why we haven't reversed this already. It just doesn't make any sense to me. And I would
but
like...
you're a rational, unencumbered human being.
I know,
right?
I know.
Like, so you look at this and you're like, and I do the same thing, by
Right.
the way.
Yeah.
I look at it and I'm like, this is not rocket science.
Right. But okay, so yes, and for all the legislators who are saying, let's break up big medicine, this is a way to start, because this starts to reintroduce competition.
Like true competition,
Yeah.
not this fake shit we're talking about.
Correct.
Yeah.
Correct.
I couldn't agree with that more. You know, it's funny because I've thought, I've set my retirement for about 3 years, a little less than 3 years now. And I've entertained the idea of sticking around, and I'm probably not going to stick around, but I've tried to talk to folks in my practice about saying, like, why don't we offer transparent pricing on the things we do? Like, let's bundle it all together. Let's start breaking this cycle, and then you can go to employers and say, look, we can be your orthopedic provider, and these are the costs that you can factor into your projections, like your economic forecasting of services. I mean, the problem is we're developing these models. They are developing de novo in the market. They're just not developing at scale right now. Yeah. So, and that's the problem. I mean, we're losing water out of the dam and replacing it drop by drop. Yeah. I mean, it's just not, it's not a sustainable kind of thing if it happens organically. I mean, because, by the time it gets legs organically, you'll be 20 years down the line, and the system will just be dead at that point.
So will I, but that's okay.
Hopefully not 20 years from now. My God. I can't wait to see you at 80, 85. Well, you're going to be a whippersnapper then.
Oh, my God. Nobody wants to see me at 80 or 85.
Oh, I want to see you at 85.
My kids are like, oh, God, Mom, no.
Oh, I'm saying, oh, God, yes. I want to see it. I want to be a part of it. I definitely do.
All the leashes will be off. All of them.
Exactly. Once you're not that inhibited anyway, but once you lose a little bit more of your inhibition, whatever little you have, God help the world, man. Holy moly. Guns a-blazing. Can't wait.
Yeah. Well, okay. So let's reverse Section 6001. I mean, I think that should be the marching order right now. One of the marching orders. There are several, but let's get on that. There are people already working on it. So let's go help them.
I'm in. I've been there. I've done that.
Yep.
I've done some of that work in the past, and, with a little more free time, I might do a lot more of it.
Yeah.
We say it all the time, but, things don't change in silence. And you may feel as a patient or as a clinician you don't have a voice, but you do. You have a representative to Congress, you have 2 representatives to the Senate, and emails and form letters don't work. Find out when they're in their offices, make an appointment, and talk to them about, as a patient, your reality in healthcare, as a clinician, your reality in delivering care and what it's like. And that matters. That resonates. One of the things that I've always been very interested in, is, we say a lot of nasty things about representatives, and they're all on the take, and they're all getting money, and there's special interests that influence them. But they don't know in many circumstances what they don't know. And when you sit down with them, because I've done it, I've gone to Washington and lobbied, they are so grateful for the information that you're providing, and the clarity. I mean, because we are all very clear on what's problematic. And if you provide that to them, they appreciate it.
Well, I mean, this is where I say this in almost every talk that I give, which is that we take what we do for granted because we do it all day, every day. And so we kind of just assume that what we know, other people know as well. And it is really eye-opening and shocking when you talk to people that are earnest, who want to know, who want to help, and who just don't, like, they haven't had any experience of healthcare other than getting their own care intermittently, not that often. And it's completely opaque.
Well, and they get their health care. This is the cocoon that many people live in. They don't. Trust me. If my senator from the state of Pennsylvania needs health care, they're not calling a local guy and not identifying themselves and not having some influence. Right. Not that they necessarily try that, but I can tell you if a state senator from the state of Pennsylvania calls my office, identifies them as such, they're getting an appointment like that afternoon. Right. That's one of my beefs about the people that.
But I'm not even talking about access to healthcare. I'm talking about how healthcare works.
Oh, fair enough.
It is wildly complex. Even those of us who know how it works sometimes struggle to make it work well. And so, helping them, if we as physicians can go in and really be clear with them about, here's what's on the docket for you, here's my experience, here's the data that I have to back it up, and here's what I'm asking you to do. It's a pretty quick conversation, and you might be really surprised at how receptive they are.
Yeah, I agree. I guess my only point, and I don't need to beat
you're going to beat that dead horse. I know you're going to beat it.
No, but the complexity of this, all of our patients understand the complexity of healthcare. My point is that the complexity of healthcare is completely opaque to them because everybody manages every aspect of their episodes of care so that they don't have to experience the complexity, I guess was what I was trying to get at.
Yeah.
And this is where patient stories and patient experiences are extremely helpful. I've adopted the position as a clinician now where I'm not running cover for a fucked up system anymore.
Yep.
So, and we've talked about how the system leverages our goodwill against us. And so we are the forward face of healthcare, and we are where the interaction happens. And I'm at a point now where I'm like, look, I am here talking to you, taking care of you. I have no control over anything that happens outside of this room.
Yeah.
I had 5 denials of surgery this week alone.
What?
These are people who, and so I spend hours on the phone. My PA spends hours on the phone talking to somebody who's like, well, listen, our sheet tells us that this patient doesn't qualify for surgery. I'm like,
stop.
what sheet is that? Who put that sheet together? I can tell you what our research in our own, our published research shows about this. Like therapy doesn't work for end-stage arthritis, but everybody's got to go to PT. And, or, oh, you know what? They didn't get therapy, you got to send, so you got to cancel their surgery, send to the therapy that's going to make them fucking miserable because it's going to make their pain worse. And then when they finally clear that hurdle, now they have to wait another 6 weeks for surgery.
Right.
And these are people that are trying to work and trying to live and trying to figure out how to manage being away from productive work for 8 weeks while they recover. How did, so I'm like, I'm not taking the hit for this anymore. I am not, when they call and they're all pissed off that their surgery got canceled, call your insurance company.
Yeah.
Call Turning Point, the grifter middleman who makes these decisions for insurance companies.
Right.
Now.
But then we get stuck in the middle because this is the part of the conversation that Victor was talking about in one of our recent episodes, where we're putting the tasks on the patients. And I get it. I understand why people do it, because it is so miserable to do this all day, every day. And it makes us, it makes me think, where are we? Where are we?
I couldn't say that any better. I will tell you though, and we still run a lot of cover for our patients.
Oh, I know.
But
yeah.
Again, at some point, the reality of the system that they exist in, that we exist in, has to become known to them. And sometimes, and it sounds insensitive, and I don't mean it to be insensitive, because I don't want my patients to have to worry about anything other than their health. But in a system where nobody seems to give a shit about their health except for me, like the insurance company doesn't care, the hospital doesn't care, they just want to get paid or not paid, one or the other.
Right.
I think there's value to some degree in them experiencing what the system has become, so they can become an advocate.
Well, yeah. And I'm not saying that, don't take this personally. Because it's not just you that's doing it, right? It's not just you that's doing it. I've heard this from a lot of people, a lot of physicians. What's happening is that the conflict between Goliaths, between the health insurer and the hospital, is getting shoved down to the front lines. And now it's the patients and the physicians.
Yeah.
And why are we continually shouldering the dysfunction of these systems that are making billions? Why?
Amen. I embrace your comment. I don't feel threatened by it, because it's true. It is absolutely true. And I guess the pushback on my end is to say, my pushback with my patients is to say, I'm just the guy trying to deliver care. I have an ideal that I would love to work within, but the reality is very different than the ideal. Let me just tell you what's really going on. And to your point, the downside to the reality as it exists right now is that they're suffering.
Yeah. And if this is an employed insurance situation, you ought to be going to your employer and saying, hey, do you know what I'm going through right now? Go to HR, go to benefits and say, hey, just need to fill you in on a little secret about what's happening with my healthcare. You want me back to work? Yes, I really want to be back to work too. Help me fight this fight.
That's actually a really, that's a very, very smart strategy. Because a lot of this, if you talk about a group of people, if you said to me, what level of the healthcare system do I think would be most fruitful in attacking, like your first foray into this kind of revolution, it would be employee-sponsored healthcare.
Yep.
Because employers, particularly large employers, they don't recognize either what leverage they have in the system. To them, health benefits are just a requirement to be in business. But they don't realize that it can be transformative in business too.
Right.
Like, if General Motors went to United Healthcare and said, hey, listen, this shit isn't working for us. Or start to explore different options. I mean, there are employers that are...
If there's a medical professional society that says we can no longer afford insurance for our employees, that's a story that should be on the front page of the New York Times. I heard about that the other day.
Really?
Mm-hmm.
Yeah, but you know what happens to that story? Gardner Harris said it perfectly in No More Tears, is that the guy who wants to write that story all of a sudden finds himself an editor saying, hey,
true.
listen, I got a call from United Healthcare who
true.
spends millions advertising with us. If this story gets out, we're not going to have their advertising revenue.
So they need to go find somebody on Substack.
Well, yeah.
All right. Well, I think the bottom line here is we have a path, a potential path. We need to work this one hard. And there will be more coming in the coming weeks, months. So support the House Bill 2191 and Senate Bill 1390. And we'll have those on the show notes. We'll have them on our website. And let us know if you have questions or send us stories. We would love that.
Agreed. You've been listening to the 43cc podcast. Our amazing, remarkable, lovely producer is Jill Ruby.
You want to vent, rant, or ask a question? Or send us a story? Or you want to know how to get involved? Send us an email or a voice memo at hello@43ccpodcast.com and have a look at our website at 43ccpodcast.com.
And while you're at it, while you're on the website, there's a whole bunch of things you could do. Surf our website. There's a lot of interesting stuff. You can find our entire catalog of shows and show notes. Dig into the show notes. They're amazing. It's got a lot of stuff in there, a lot of resource. We've dropped 70-ish episodes now. So really, go have a look. Our guests are amazing. The content is amazing. Check out our reading list. This is a kind of a new feature on the website. We've started to post some of the things that we read and the books of the authors that we've interviewed. It's a great way to get started. I will tell you, my education in all things related to healthcare is part of that reading list, and it's amazing. Then, if you have a few thoughts, give us some notes. Send us some information. Look for the Speak Pipe widget, the microphone icon on every single page, and send us a voice memo directly. We love featuring real listeners' voices, and we'll keep you anonymous on the air if you'd like, promise. And finally, you can drop a donation to keep the content flowing. Cheers to our listeners who have already sent one, and we'd love to have more of you in the family.
It's a good family. It's tight.
It's a great family.
Peace, y'all.
Peace.